had an adult hematologist, Dr. Johnson Liu, and a pulmonologist, Dr. Charlie McCaslin, on with us recently to discuss this pandemic. Tonight we will have hematologist and SDS researcher Dr. Seth Corey with us. As you are logging on, please let us know where you're logging on from.
Yes, welcome everybody. We are excited to keep this going. It's kept Nicole and I very, very busy, which I think is good right now because otherwise I'm just going to sit and replant my garden and sew masks and clean my house.
Rocking right now. I am so thankful for my garden because vegetables are hard to come by right now.
They are. They're right next to toilet paper. Can you grow toilet paper?
I can't. I wish I could. Maybe Dr. Corey can help us with this.
Maybe.
If you can swear.
As a reminder, this show is brought to you from the Shwachman-Diamond Syndrome Foundation, providing support for families around the world. And the show is public, so please do not post anything private. Dr. Corey will not be able to answer any very specific questions. We will put all these shows on our SDSF website as well as YouTube. There'll be subtitles available, and you can translate it into your native language.
Yes, so like Nicole said, that tonight, let's try to keep the questions very general because Dr. Corey is a researcher as well as a hematologist. And so and asking very personal questions that should definitely be directed to your doctor are not going to be able to be answered just because they're medical professionals and they can't do that on this. So we are super excited because our giveaway tonight is not toilet paper again because we already gave you that essential. So our executive director at the Shwachman-Diamond Syndrome Foundation crochets, and she's very, very talented. She's made neutrophil ornaments for us. I think she's even crocheted a gallbladder. So we asked her to make a very special giveaway for us tonight.
This is Rona. She's not that happy, as you can see, because we're all staying home and she's losing hosts. She rivals Karen. To win Rona, all you need to do is interact with this show in any way. Send us questions, comment, share it, create a watch party. Just interact in any way, and you could win Rona. Watch
parties are super helpful. I tried one last week after the show to share it further, and it was actually pretty easy because then you could see your comments with the people you've invited and the comments on the video itself. Yeah, just as a reminder, when you're logging in, let us know where you're logging in from. We want to know where you are. We want to know how your mental health is. How are you doing? Nicole likes to know your favorite land mammal. And
it's a good opener.
It's a good one.
It is.
Do you know, I learned the other day, though, that we were playing some game with Evelyn, and a duck is not a mammal. And that was a very new...
What is it?
It's not a mammal. I don't remember. It's a bird. It wasn't a mammal. That was weird. So I got to research it a little more.
Now we need to find it.
I felt like a duck was a mammal, and it wasn't.
Oh, because it lays eggs, Dr. Corey said.
Oh.
A wealth of information.
And no breast milk.
No breast milk.
What would we do without Dr. Corey? Many of you know Dr. Corey from his SDS research with zebrafish. And so I'd like to welcome him onto the show. Dr. Corey, can you share your position in the hospital where you're currently practicing?
First to be deployed in case there should be a surge. I'm a staff member in the Cleveland Clinic Pediatrics program and a member of the Cancer Biology and Translational Hematology Oncology Research departments at the Lerner Research Institute, part of Case Comprehensive Cancer Center. So I'm a professor there.
Interesting. How is Ohio right now?
How's what?
How is Ohio?
It's not Virginia. The Cleveland Clinic is an amazing place. The research environment that I came to, that I was recruited to, is one of the leading departments in myelodysplastic syndromes and the genomics of MDS and AML, led by my friend, colleague, Dr. Jarek Majewski. Cleveland is not as pretty as Richmond, Virginia. Let's just say that. Yeah. And I missed some of my friends back in Virginia.
So sorry for that. Dr. Corey, we have a lot of new families with us since you started your SDS research. So some of them may not be so familiar with your research. Can you explain what you've been researching?
So my area of interest is in the bone marrow failures, more specifically in the inherited neutropenias, and more specifically in severe congenital neutropenia and Shwachman-Diamond syndrome. My particular interest is to identify the pathogenesis, or how these diseases arise, why do they cause bone marrow failure, and then, as importantly, to determine what are the mechanisms, what are the risk factors for a particular individual to go on to develop the life-threatening complication of myelodysplastic syndrome or acute myeloid leukemia. So we've used both mice as well as zebrafish, as well as mathematical models to try to tease apart and enlighten us as to these processes. And there you see a picture of the fish. What we did is, so relevant to our discussion on coronavirus and much that you've heard about modeling coronavirus, one can say all models are wrong, but some are useful. We believe that the zebrafish model for Shwachman-Diamond syndrome can be very useful. Joanna Roman, who cloned the Shwachman-Diamond gene, has made a knockout mouse. And unfortunately, the mice die really within the first trimester or earlier. So what we did was to take zebrafish and use a new technique called CRISPR. Okay, this is a different curve. Okay, we used CRISPR genome editing to knock out the Shwachman-Diamond gene in the fish. And believe it or not, even though fish don't look like people, the gene for Shwachman-Diamond syndrome, SBDS, is 90% conserved with the human gene. So there's a high degree of conservation. And what we found was that the fish do survive development, that they are small. And if you go back to that picture, you can see the difference between the fish in their sizes. So they have, if you will, short stature. They have neutropenia. They have pancreatic insufficiency or pancreatic atrophy. In addition, they have some evidence of defects in their bone formation. So there, in that picture on my right, on the top is a normal fish, and on the bottom is a brother or sister of that fish, same age, but now with the gene for Shwachman-Diamond deleted. And so you can see that the fish are smaller. Now, do you want me to continue?
Yes, you're good.
Okay. You can stop me until you get bored. So we are able to recreate the what we call the phenotype, the appearance of Shwachman-Diamond in the fish. And moreover, we are able now to take a look at the sort of responses at the genetic level, as well as the biochemical level, to see what genes, which are the instructions for all sorts of things, are upregulated or downregulated, depending upon the presence or absence of Shwachman-Diamond syndrome. And in particular, we've also seen that a particular DNA damage response called P53 is in turn effective, but it's not the only response. And we're now identifying what we call a P53 independent response. So we're able to analyze the fish biochemically. We're looking at their nutritional status, and we're looking at the effects, if you will, of starvation or malabsorption. The fish have very abnormal intestines. They're what we call atrophied, which means that they don't have all the cells present in order to absorb the tissue. And as I said, they also have an absent pancreas. So we are looking at a metabolic level, what's going on in the fish. We're looking at the genetic level to see what type of responses occur. And what we'd like to do, and we're engaged in a collaboration with Marco and Valentino in Italy, is to look at drugs that may rescue the fish by sort of forcing an expression of a near normal Schwachman-Diamond protein. Now, what I didn't tell you was that the fish that we develop do unfortunately die sort of in early childhood for the fish. But, and this is really the work done by a really dedicated, hardworking, talented scientist, Dr. Asua Oyerbide, who's in my lab. So what she's done is to make a partial rescue of the fish using a mutation that is found in kids. And the fish now live for more than a year. So we're now able to have fish that can survive for a sufficiently long period of time so that we can try to get to the question that started this off is, what are the second and third or fourth genetic changes that occur that promote the transformation in a vulnerable individual to developing leukemia? So I believe that the zebrafish model is a very powerful one to look at Schwachman-Diamond syndrome. We're also making fish with mutations in some of the other genes that are associated with Schwachman-Diamond-like syndrome, namely DNA-JC21 and EFL1. I think that's it for now. Anybody can write me if they have any questions about the fish. So it's a good fish story.
It is a pretty good fish story, and it's ironically much different than all the other fish stories where the fish gets bigger and bigger and bigger.
Only the people telling the tales amplify the story of the fish. Yes. So the fish, we're pretty excited about that. And what we'd like to do, obviously, is try to identify risk factors so that we can educate the parents as to say, will your child have a greater risk than another child or lesser risk of developing leukemia, so that the goal is really to intervene very selectively with a stem cell transplant before the bad leukemia clone arises. In addition, we'd like to use the fish to screen for drugs, like a pill that you can take like Creon, but instead of sort of helping malabsorption, you're really modulating every organ in the body that might be affected by Schwachman-Diamond. And let me just finish one more thing that the fish can do and tell us, and that is we can see evidence of changes in other organs that may not be sort of notable by clinicians. We do see changes going on in the liver, and we do see changes in the eye. I'm very curious if any of you have noted that your kids have a greater risk of developing, need for glasses or some other eye-related issues. We've looked only superficially at the brain. We cannot look at the lung because the fish don't have lungs, they have gills. But we can look at all the other organs and we can watch them and see what happens when you lose that normal gene.
We had a few different questions come in about the fish already, and so I figured we'll just jump to those real quick. Joan had asked, how is the P53 affecting the fish? Is there any morbidity?
So what we've done is to breed the fish with another fish that is mutant P53. And what we find is that when we have the fish that are both deficient in P53 and Schwachman-Diamond, that there's no greater survival. Now, for those of you who may not be so attuned, P53 is sort of called the guardian of the genome. It's sort of a major sensor of any sort of stress, whether it's stress from too much oxygen, or stress from too much DNA damage, or stress from too much, if you will, even starvation. And what P53 does is to turn on a bunch of other genes in order to give the cell, the animal, a time to rest and try to recover. So it is one of the most commonly mutated genes in adult cancer because you don't have that response. So to answer Joan's question, the P53 is involved in a stress response, but it does not appear to be the major effector or mediator of survival or the loss of survival in the fish. And let me just, to bring this all to the person, there was a controversial paper from the group at Harvard suggesting that a number of individuals who had myelodysplastic syndrome, when they were sequenced, were found to be, if you will, silent, undiagnosed Shwachman-Diamond syndrome individuals. On the other hand, Dan Link published a paper in Blood showing that there was P53 mutations found in children with Shwachman-Diamond syndrome, and that the mutations did accumulate as people aged, but none of those individuals had leukemia or myelodysplastic syndrome. Lastly, we've sequenced, in collaboration with the Italians, 6 or 7 children, young adults with Shwachman-Diamond syndrome and acute leukemia, myeloid leukemia, and we found no mutation of P53, although we did see something called a variant, a non-pathogenic variant. So after all that I just said, what does that mean? It's not clear that P53 plays a role in the transformation to leukemia. It's something that does require further investigation. Okay.
Thank you.
So,
At what age does the pancreas in the fish atrophy?
okay, so now we're talking about fish years, it's like dog years. So you can't really compare that to people years. So it takes basically 4 days for a fish to develop from a fertilized egg to a tadpole. So that is comparable to like 9 months of pregnancy, if you will. All their major organs really develop within 24 to 36 hours, pretty quick. And so we talk about days post-fertilization. The fish are doing well until 15 days post-fertilization. Maybe we can compare that to being an infant. They do well in part because they can thank their mothers. Their mothers donate both the protein in the egg for the Shwachman-Diamond syndrome, and they also donate the genetic material for more protein to be made. Then at around 8 to 10 days post-fertilization, the levels of the protein start to go away because there's no natural gene that's being expressed. So around 15 days post-fertilization, which would be, a couple months in a baby perhaps, if you can make that comparison, then the tissue starts to, what we say, atrophy. The cells don't divide, they start to die off, and the organs start to shrivel up. In particular, the organs that we find shriveling up are the intestine, the pancreas, and the back of the eye called the retina. Those seem to be the major organs. The bone marrow in the zebrafish is not in the bone marrow, it's in the kidney itself. And grossly, the kidneys look okay. The liver does start to fall apart a bit between 15 to 21 days. So there's this vulnerable period about a week after the protein disappears that the tissue starts to deteriorate in the fish.
I can't believe I never knew all of this about fish. I didn't, because I was waiting to say, but what about the bone marrow? And you were like way ahead of me, and I had no idea. Like, so is the bone marrow itself in the kidney, or is it just like, representing from the kidney?
So when I say the bone marrow is the part where the blood cells are produced in bones in mammals. And fish are not mammals, they're fish. And evolutionarily, the kidney seems to be the site for blood cell formation. One can go into a little bit more detail and talk about like the fetal liver and the area around the major artery called the aorta. But in essence, in the adult fish, the blood cells are produced in the kidney. Now, some of that remains in us because the kidney is the source for something called erythropoietin, the hormone that makes red blood cells. But the bone marrow does not exist in the fish. It's the kidney that's the site of blood cell production.
That's so interesting. We had a question come in, and then we are going to move on with the agenda. It's from Christina. She said, is there any correlation between the particular mutation the child has and then the increased probability of the progression of AML or MDS or aplastic anemia?
Yeah, that's a good question. And I think that there is no clear-cut genotype-phenotype correlation, meaning the genotype is the exact set of, we don't call it necessarily mutation, we call them variants, pathogenic variants. There seems to be no relationship between the types of mutations that a particular person has and the risk of developing MDS, myelodysplastic syndrome, or acute myeloid leukemia. The question is, what is there that increases the risk? Is it a probabilistic event like bad luck occurring? Is it a stress of an infection that might shift a response to either bone marrow failure, loss of all the blood cells, or towards a particular type of malignancy like leukemia? There seems to be no known genotype correlation at this point. So we have to figure out what are the stress factors, what are the genetic mutations that we need to screen in an individual to be able to catch a person before they develop leukemia and intervene and have much better success than with stem cell transplant, as was recently reported by the Europeans. So this is the purpose of our studies, is to look at, in particular, the loss of chromosome 7. So this gene is located on chromosome 7, and chromosome 7 loss occurs fairly regularly among children with the inherited bone marrow failure syndromes. And the question is that loss of chromosome 7 sort of a counter, like a protective mechanism? Or are there what we call tumor suppressor genes that are lost on chromosome 7 that increase the risk? So having a fish model, we can interrogate, evaluate the role played by candidate genes, candidate tumor suppressor genes. We hope to get those answers.
Amazing. Thank you so much for all that information, especially for the families that haven't been following your work for a while.
Yeah, I hope feel free to interrupt if something is too technical.
No, you're doing great. You're doing great. We're gonna.
I think it sounds really good.
We're gonna transition now to the coronavirus. Some people are at home knitting, some are baking, some are watching movie marathons. You are so busy, yet you found the time to compile massive amounts of data to help explain this pandemic situation, and you've been posting it daily. And I'm finding myself and a lot of people following your posts optimistic, hopeful, and you explain it in such an interesting way. So that was one of the reasons why we wanted to have you on. Can you explain to us what data you're compiling and why?
Okay, well, I started this about 2 weeks ago because I noticed that my family, friends, and patients were getting very anxious about this sudden burst on the world scene, the coronavirus. And I felt that there was a high degree, as one sees, of panic. And I think the purpose of a healthcare provider is to try to present the information as accurately and as honestly as possible, and at the same time be hopeful. So what I began to do was just to take a look at the data. We have I've been working with a mathematician for some years to look at mathematical models for why kids develop leukemia. I sort of compare this to hurricane tracking. And that is, having grown up in Florida, come May, we always look for storms that may be developing. And we want to know in Florida, other places, Texas, what's going to happen to that storm? Is that storm going to sort of die out in the Atlantic or the Gulf, or is it going to gain momentum, go from a tropical storm to a hurricane, whether it's a Category 1 hurricane or Category 5 hurricane? We want to know, when is that hurricane going to hit land? And we want to know whether it's going to hit Galveston or Jacksonville or Savannah. And so what weathermen people do is to get all the data and put together a mathematical model and develop these cones. These are models. And these models are typically wrong, but they're useful. And the models have to be constantly revised. So my goal is to make models to predict for a particular individual their risk of developing leukemia. And so with that same sort of like background, I started to look at the data that was being accumulated by various public health agencies. And what I initially saw was that, yes, this is a serious worldwide infection epidemic. But at the same time, I was looking at the numbers and looking at the trends and trying to convey to individuals, yes, this is serious, but it's not catastrophic. This is the rate of increase in the number of new cases. This is the sort of the rate of death. And I tried to provide the data in a way that an average person could understand, and to try to be reassuring. And so using Facebook, I've written sort of a daily note encouraging people to keep calm, wash your hands, avoid sick people, do the social distancing, physical distancing thing. And so what I do is I take information from an aggregator of information. It's called worldometers.com. And they've been aggregating feeds from around the world and from the United States. And Johns Hopkins also has a page like this. And I've been just basically doing back of the envelope calculations and looking at the numbers and sort of doing my hurricane tracking and trying at the same time to try to convey to people that read the Facebook page sort of what this means. If you read the newspapers or listen to the news, you sort of get the headlines. And oftentimes the headlines emphasize the bad more than the accurate, and trying to put this into context. So that was what motivated me, was to try to just convey the information to the lay public with the hope that, yes, people should be concerned. People should try to maintain social distance, physical distance, because the physical distance is really the equivalent of a vaccine, which we don't have. And that the goal is to mitigate the spread of this disease, and to try to convey to the individual that not all people have the same risk. Not all places in the world have the same risk. So it's really trying to get accurate information so that people can be hopeful, because it's bad enough to be socially isolated, to worry about losing one's life and losing one's job, and to see that we will get through this. Almost all of us will get through this, but our behaviors will change.
Can you summarize your latest findings in this data? We have your last two slides.
Okay. So let me just say a couple things. One is the epidemic in the United States got off to a bad start as far as number of deaths because there was an outbreak, a cluster of cases in Seattle in a nursing home. And then the epidemic sort of shifted to the New York tri-state area. And the epidemic, the numbers are really driven. The number of cases and the number of deaths are driven, unfortunately, by the greater New York City metropolitan area for a variety of reasons. And that there is geographical disparity between states and risk. So some of the general lessons from this right now is younger people have mild asymptomatic cases. That the real risk is to individuals over the age of 60, really over the age of 70, particularly those with an underlying condition, most prominently heart disease, chronic lung disease, diabetes, obesity. And many of these factors sort of go along with each other. Ohio, I kind of like to think is sort of typical of most of the non-New York, non-Louisiana part of the country. And the governor here instituted physical distancing relatively early. And I think that in many ways, what goes on in Ohio may be typical for most of the country. There appears, so this slide that you have here is from yesterday's Ohio Department of Health reporting. So there's been 3,700 cases and 102 deaths to date. And if you look below, they give you a little bit more information. Roughly about 9% of those tested are positive for coronavirus of the Wuhan strain. About 9% of those are in the intensive care unit. About 25% need hospitalization. The median age of a person infected is 53 years of age. Data not shown here shows that, unfortunately, for an individual who's in the 80s and above, the risk of dying is 17%. For those that are 70 or greater, it's 7%. For those 60 to 69, it's 3%. So you can see that with every decade, it sort of doubles. There's only been one individual under the age of 50 among 1,700 cases who has died. So I think that, if you're a parent of a child, you can feel less anxious. I've been trying to reassure my daughter with her 2 kids not to worry. That, if you're under the age of 50, you may get a bad case of the flu, fevers, muscle aches, but you're unlikely to need hospitalization and you will recover. For those that are at high risk in that age range and with the underlying diseases, you really should unfortunately maintain isolation, good hand washing, limit your exposures. So, I'd be happy to take more, specific questions, but I've been tracking this for about 2 weeks now. And I feel pretty comfortable. If you hold on for a second, I need to plug in my computer. I feel pretty comfortable that this disease, we will get through this disease, and that the disease will peak in new cases sometime around Easter. I do not think that the original worst case scenarios of 2 million people dying, which is just unimaginable, is going to be. Based upon what I call back of the envelope calculations from 2 weeks ago, something like 40 to 80,000 people unfortunately will die. which will make it worse than a bad flu season, but not considerably greater. The difference is, in part, we don't have a vaccine. And I think that, the vaccine gives people some reassurance. And here we don't have any of that vaccine reassurance. And it's invisible. And people are scared. And I think that with these numbers, my goal is to try to reassure people that we'll get through this.
I love your backstory of why you started this. I didn't know that's why. I just thought maybe it was fun or it was a side project for work. I love that you're trying to reassure your loved ones and people that you care about. And obviously, as a researcher and a doctor, you're someone that people look toward. I know I have friends in the medical community. I'm asking them questions. That's beautiful, your backstory, especially with your daughter, of trying to reassure people.
And my son too. My son has a 12-month-old, 13-month, so he too. He's not so much worried about his kids; he's worried about himself.
Yeah. The CDC has said many times those with pre-existing conditions. You could outline some of those pre-existing conditions. Obviously, the SDS community is naturally nervous about this, as anything kind of hits us hard. However, there's been some rumblings that lack of neutrophils may, I'll say a big may, actually help someone with COVID-19. Can you explain that?
Well, right now, this is really more story making or hypothesis generating, that there's very little data other than one of the pre-existing conditions is some sort of immunosuppression. Now, mind you, this is all within the prism of the adult world, okay? And not really about kids. There is one paper out there about the Chinese experience with kids on chemotherapy, which was basically not terribly frightening, but there's very limited information. And you're talking about Shwachman-Diamond syndrome or kids with inherited neutropenias, which is a rare population. But, your parents of a child with Shwachman-Diamond syndrome, so you're focused on that condition. So all I can do is hypothesize and try to give you my educated guess, something that I would like to study in some way, which is the role of infection in bone marrow failure. But the problem why people die with coronavirus is, one, they're old and they have underlying conditions. They develop something called adult respiratory distress syndrome, which, even though it's called adult respiratory distress syndrome, could occur in kids. And what adult respiratory distress syndrome is great inflammation going on in your lungs, where your lungs fill up with fluid and the air sacs can't open up and the lungs become stiff. And it's driven by inflammation. And one of the markers of inflammation that was reported by the Chinese was that those that had bad cases had a higher neutrophil count. They also had a lower lymphocyte count. So neutrophils contribute to inflammation in the lung. So conceivably, there may be a tipping point, if you will, where if you don't have so many neutrophils, you're going to downregulate. You're not going to have as severe an inflammation in your lungs. So if you want to look for a silver lining for a child that has, a neutrophil count of 1,000, an ANC of 1,000 or 1,500 or 750, it is that the neutrophil numbers are not as great as 10,000. And so that there's less likelihood for an severe inflammation in the lungs. So that's my hypothesis. This remains to be proven. I'm not certain how one can show that clinically because there's so few cases. Reassuringly, for whatever reasons, this particular coronavirus has not been deleterious, harmful to children and young people. And I don't know why that is. Part of it could be that adults have seen coronavirus in the past and will mount a stronger immune response, or it could be something else. So I think, as a parent of a child with Shwachman-Diamond syndrome, you should look for fever, you should look for cough, a progressive cough, and notify your primary care physician as soon as possible. On the other hand, there is no particular treatment for coronavirus at this stage. People are talking about antibodies, and people are talking about hydroxychloroquine, which is interesting because it's an anti-inflammatory agent. Some of it is anecdotal, and some of it is based upon a study from France involving 80 patients. There may be two roles that hydroxychloroquine and azithromycin might play. One is on prophylaxis, preventing the virus from becoming established. The other is in very sick individuals. And then there's antiviral agents that are being tried. So at this point, if you look for signs and symptoms in your child, it would be useful to the community with respecting HIPAA confidentiality to somehow collect data on a voluntary basis. Maybe the Shwachman-Diamond Registry could do this, but that has to undergo IRB approval, Institutional Review Board approval. So I think in many cases, sort of circumnavigating that, but sort of word of mouth, parents, support groups, trying to get an idea as to whether this is a problem or not, that remains to be shown. But if I can suggest that perhaps your child's neutrophil count being 1,000 may not be such a bad thing, maybe I'm right.
There are a subset of SDS patients who are over the age of 18. We have quite a few adult patients. What do you think? Because then obviously they would fall into that category of being older than 18. And so that's when, it starts getting more known to be risky. What about patients like that?
Yeah, well, what I find interesting, and I don't have, I'm privy to all the information, and I know that you've been, there's a physician that's interested in diabetes, but there seems to be some correlation between diabetes and increased risk of severe illness. I think, again, we need more information about this. Try to get an idea of what's going on. If somebody's over the age of 18, again, with fever, cough, then they should contact their primary care physician. I guess in many ways, let me ask you, how many of you have had issues with, we immunize every child with influenza. And, in the years past, the question is, has that been an issue among patients with Shwachman-Diamond syndrome? The vaccine is, maybe 70% effective, so there will be some failures. I think you as parents are concerned, and you engage in your own form of micro herd immunity because everybody in the family is typically immunized. So if one person's vaccine doesn't work, someone else's will help to cut down the infection rate. I guess, anecdotally, any evidence of problems with the flu in the years past?
Nathan's had the flu quite a few times. I can't remember exactly what years or strains, but he also catches every viral infection under the sun because we have underlying lung issues on top of our SDS. But I know with the vaccine itself, we've had quite a few kids react to the vaccine in an unnatural way. Not so much so that they couldn't get it the next year, but that they had to do it under monitoring. Yeah. And not just like an allergic skin thing, but they would get these weird kind of infections from them. I know I can't tell you offhand exactly what, but I do know that's an issue.
Yeah. So I guess the issue is somebody over the age of 18. I see the questions. I think if somebody has an underlying disease in addition to Shwachman-Diamond syndrome, whether it's a cancer or diabetes or heart disease, that would increase the risk regardless of the age.
Thank you for that.
Yeah.
You made some observations on your posts about confounding variables, which I think is really interesting, like the Italian kiss greeting. You're also adding a lot of funny humor about Texas, where I live, hasn't been hit as hard as it could be considering our population. You've made funny jokes like maybe it's our barbecue. I hope it is our barbecue. I'll keep eating barbecue. Maybe our breakfast tacos. But I really think that's interesting because there are so many confounding variables and nobody really knows.
I've often told the friends, if only the rest of the country were like Texas, we'd be a lot better off. I think there's multiple, so it's sort of interesting from a medical anthropological perspective as to country disparity, and by the same token, state disparity. And I think we have to look at New York as a outlier. We can look at Louisiana and Mardi Gras, and I'm sorry, but I went to medical school in New Orleans, so I know how the lifestyle is in New Orleans. I don't understand Detroit. Friends of mine are from Michigan, so I may start to take a look at Michigan. I mean Detroit, okay, not Muskegon. What's interesting is, I mean, California is twice the population of New York, but it's got 1/10 the number of cases. Now, there's I think we can think about issues like population density, the use of the subway, some, cultural events. Texas had the smarts to cancel the rodeo and South by Southwest. New Orleans wasn't so smart. It kept on with Mardi Gras. So there's some cultural differences between the states. For countries, that's fascinating because you have different cultures. I think Italy and Spain have been hit pretty hard compared to Germany and Austria. I'm not a medical anthropologist, but thinking about Italy and Spain, two countries where there's an older population, where there tends to be larger families, whether there's also intergenerational living, transgenerational living, from babies to grandparents. So this may account for much of the reason why Italy and Spain have been hit worse. There may be host factors, genetic factors. Some of you have heard about that terrible family in New Jersey where 4 of the 9 died. And one wonders whether it's the environment or whether there's something genetically particular to that family that, for instance, caused them to have a more severe inflammatory response. And then, as you said, Nicole, about kissing, if you go to France, they kiss 3 times, or, Italy, so there's some issue of social closeness and proximity that may, be a contributing factor. But I think, we're going to learn a lot of lessons from this unfortunate pandemic, which is really a major colossal event for the entire world. But we will get through this.
It is, and it's kind of taken a lot of people, it's uprooted them. I've been telling families that I know is that, how to remain calm. This is something we do during flu season, not to this extent, but we do take extra precautions. And so if I'm calm, you could probably be calm, and we'll be calm together. You mentioned some hospitals are not testing for COVID when a patient tests positive for the flu or some other viral panel. What a missed opportunity to study how some patients have compounded these illnesses and how it affects this virus. What do you think about that?
I think that's a question that needs to be addressed. So let me just say, firstly, screening. I think the policy that's been undertaken has probably been the best policy available to us. Limit the number of people coming from outside the United States from hot zones like Europe and China. The issue about screening is sort of a complicated one because the FDA regulates screening tests. The screening tests have to be accurate. And part of the problem is the accuracy of the test may be 70 to 90%, which means at the very early stages of the epidemic, you're going to have a lot of false positives. So people will be, if you will, falsely isolated. So in fact, we had sort of a global universal, although it was in stepwise fashion, isolation of individuals. There will be lessons learned, about how to manage this. And what was the rest of the question? I'm sorry.
That we've had it asked on a couple of other broadcasts as well. Just the fact that there could be illnesses on top of the flu, on top of it. So
Thank you. Yeah. So one of the questions is, why do some people react with a strong inflammatory reaction and others do not? Okay. That's a profound question. Many people speculate, that sickle cell anemia became established within the population because there was a survivor advantage to malaria. Cystic fibrosis gene was established in part by resistance to cholera. Now, some of this is story making. Perhaps Shwachman-Diamond gene, the carrier state, the heterozygote, has some sort of selection fitness. So if you look at a big population, you can ask yourself, well, maybe there's subtle genetic differences between people. Some will respond to a particular virus or bacteria better or worse than another. So what are the factors? What are the host factors that contribute to this inflammatory reaction that could either be lethal or protective? By the same token, could there be environmental factors, such as co-infection? And, oftentimes we run now a big panel of respiratory viruses and enteroviruses. And so oftentimes we see kids with more than one virus being present. Is that the test being truly accurate? Or do they in fact have multiple infections going on at the same time? And do people with multiple infections have a worse or better outcome? So in one small study from Stanford, about 20% of individuals had the flu virus as well as the coronavirus. So I think there's lots of questions, a lot of hypotheses to be made to learn about what happened. And I guess the bottom line also is, how bad will this pandemic be in terms of lives lost? And how much will the disruption really mitigate, if you will, the public health concerns?
Great question. So it actually kind of segues right beautifully into the next one. It says that you predict the U.S. curve of the cases, not the deaths, would flatten around Easter. Is the U.S. doing as much as Italy did to flatten their curve? And is that why you think our curve will flatten so soon?
Yeah. Well, I think I looked at South Korea. It took about 13 days for South Korea to flatten its curve. And I'll be posting that today. It took about 18 days for Italy to flatten. There's multiple things going on. There is the intervention. South Korea sort of locking down a few people as opposed to lots of people. And to be honest with you, I don't know all the details what Italy did. Again, there was also geographical disparity in Italy, where most of the cases are in northern Italy as opposed to southern Italy. Is it because of, if you will, Typhoid Mary, somebody that introduced the illness in Milan and was very contagious? I don't know. So we shall see. But as far as the predictions go, I've been using sort of a mathematical analysis of new cases. So the change in new cases every day. And if you see that the changes start to shrink so that the increase is not as great, then the curve starts to flatten. And looking at the results from Italy and from Spain and from South Korea, I see the same trend happening in the United States. And what I'm seeing is that around Easter time, around the 12th to the 13th, we should really be seeing a flattening in the number of new cases. That doesn't, unfortunately, people will continue to, unfortunately, die. South Korea continues to have an increase in the number of their total deaths, mostly because of people over the age of 70 in the intensive care unit that are on ventilators, having a very difficult time coming off of the ventilator due to adult respiratory distress syndrome, as well as maybe there's also a contributing factor in what we call cardiomyopathy, where the heart muscle doesn't work as well. There's lots of factors, confounding factors. The models change as new data comes in, and it's a matter of getting a sharper and sharper focus. But there's been recalibration of models in England that went from 200,000 deaths to 20,000 deaths. I hate to talk about death as sort of, because each death is a person, but it's a way of sort of providing some sort of hope that the virus, the epidemic, is coming under control. Again, the worst case scenarios were issued, which caused fear in my daughter of 2 million people dying. That is unimaginable in the United States. This is not 1917 with the Spanish flu. We have modern hospitals. There's lots of big changes going on. And so the latest models coming out of Seattle, Washington is less gloomy. 100,000, of course, that's 100,000 unfortunate individuals. And I think actually it may come down to even less than that, between 40 to 80,000. I hope I'm right.
What a gift you are, Dr. Corey. This is such informative information. We're going to ask you one last question. You mentioned false positives today with screening patients. Can you explain that a little more?
So let me see. This involves a little bit of math that really, boggles my mind at times. So no test is perfect, okay? We do sequencing, and, the sequencing is confirmed by another form of sequencing, and that's pretty good. But there's sometimes where we find out that there are changes that aren't associated with disease. So even sequencing is not perfect. And so like when I have a kid with iron deficiency anemia, pretty common disease, affects 1 billion people, I order 5 or 6 tests. And at the end of 5 or 6 tests, I may not know whether that person has iron deficiency anemia or not. So what they're using is, so the message is laboratory diagnostic testing is not perfect and 100% accurate, okay? We'd like to be as close to 100% accurate as possible.
Today's been one big school lesson over and over. We've learned about ducks and laying eggs and mammals, and I feel like we learned a lot about geography. There was even some stuff in there about, fish. I mean, I'm going to count this as school for the whole week for my kids, I think.
I didn't even know there was a medical anthropologist. That's a whole category of professionals? I didn't even know that.
Yeah. Well, I had a friend who's an anthropologist. Anyway, a Chinese anthropologist. So she's perfect for this field. But let me get back to that question, okay? Because that's very important to understand. So when you take a test and it comes back abnormal, you may or may not have the disease. If you have the disease, it's a true positive. If you have the disease, if you don't have the disease and it's positive, then it's a false positive. If you don't have the disease and the test comes back negative, you have a true negative. And if you have no disease, but the test comes back positive, then you have a false positive. And that refers to what we call the sensitivity of the test and the specificity of the test. Now, if you had 1 million people and you said that like 10,000 of those individuals had the coronavirus, if a test was 95% specific, then you'd have 50,000 basically positive tests, but only 10,000 of those individuals would be affected. As you increase the prevalence of the disease, the amount of false positives will decrease, and you'll get closer and closer to having true positives being all the cases, and false positives approximating none of the cases. So nothing is perfect. And in part, that's sort of the other side to not the harm in delaying screening, but to get the most perfect test possible. What's really, really going to be important, retrospectively looking backwards, is to look at what we call serologies, the antibody responses, to see how many individuals were exposed to this particular coronavirus and mounted an immune response. And that way we'll know how many people were truly infected. And you also have to, one other thing to answer that question, is that there's a selection bias in people that get screened. These are typically people, because the kits are still somewhat, I wouldn't say scarce, but controlled. And so they're screening based upon fever and cough. And they had that, what we call algorithm before that you mentioned, which was that if somebody tested positive for one of the flu viruses or rhinoviruses, that they wouldn't go ahead and test for coronavirus. I think that was a mistake, that we needed to get all the information. So I hope that, addressed that question about false positives. And, I think the bottom line is I have faith, and I believe our public health authorities, they've gotten their act together. I think the measures are being done. Unfortunately, the critical problem was getting the suppression of information from China. And much could have been averted. And hopefully we've learned a lesson for the future. These things will continue to reemerge.
There was a question that snuck by us, and I just realized it. Someone had asked, I work at a hospital where we're seeing children, and I'm thinking she's meaning children patients. What precautions should they still be taking?
You're working at a hospital and you're seeing children with what?
As patients.
With documented COVID infection?
I'm not entirely sure.
Yeah. Well, I mean, what's interesting is to take a look at the number of flu cases. So up until a couple of weeks ago or a week ago, we were still seeing lots of influenza A and influenza B. But the total number of influenza cases, I think, will be down this year compared to previous years, in part because of the physical isolation as well. So I think good advice, wash your hands very well. Try to avoid people that are sneezing and coughing. Wearing masks is really to protect the individual from contaminating other people. So when I go into a hospital room and there's respiratory precautions, I'm the one that puts on the gown and the mask. In many ways, it should be, unfortunately, the child should be wearing the mask. So wash your hands, wear protective garbs whenever possible, avoid people that are sneezing and coughing as much as possible, and you'll do well.
Okay, we promised you that was the last question, but we totally forgot our burning question for tonight.
Yep.
So late breaking news. So I think Apple or somebody posted an article like right before the show started. Tigers at the Bronx Zoo have tested positive. We have to know what you think about this.
Well, that's the coronavirus went from bat. This is the speculation that it arose in a bat. Bats, like Halloween bats, are a reservoir of coronaviruses. And in China, they have these wet markets where they eat weird things, okay? Unusual things, okay? And somehow the bat, if you saw the movie Contagion, I think with Gwyneth Paltrow and Matt Damon, it's kind of close to true. So what happened was, I think a bat peed onto a pangolin, which is a ugly looking aardvark, okay? Sorry.
So it peed on them? I thought it bit the pangolin.
It bit, peed, did something, okay? The animals are all close together.
There was a transfer of mucus from one animal to the other animal, and they were probably mammals.
And then allegedly, this is a delicacy in the open market. and it spread from one animal to another animal and then consumed to a human. And that sort of triggered this epidemic. So pigs, and we've been talking to a collaborator to look at coronavirus that infects a pig. I don't know about the tiger story. People have asked me about dogs. Okay. I guess it's conceivable that the coronavirus could situate itself in a tiger or a dog for a while, but I think it's unlikely. You shouldn't be having a tiger as a pet anyway, okay? But don't pet the tiger. But I think for your dogs, there's no evidence to date that the dog is a reservoir or a vector for infection with the coronavirus. I haven't seen that. Must have been in the New York Daily News.
I'm not entirely sure where it was. I just know it got shared to us, and then someone had asked us to ask it. There is one last question. I promise
not to pet a tiger, okay?
No petting tigers. No, I will tell them to not pet tigers. Just don't pet tigers. And a lot of the zoos are closed right now anyway, so.
Unless it's an LSU tiger.
Oh, well, I mean, aren't they under quarantine too, though?
The LSU tigers? Yeah, I guess so.
So no petting any tigers at all. No cool cats and kittens here.
Mm-hmm.
One last question came in, and she said, and I think it's a pretty good one. She's read that there's been many people that have shown symptoms that are not being tested because it's not likely to change the outcome. They are told to self-quarantine for 14 days. Do you believe that the number of infected individuals is actually much higher than what's being reported?
This is the easiest question of the evening. Yes. Yes. There are, this is where the antibody testing of the population at some point, and I think it will be done rather soon, within the next month or so.
I believe I think it's an article about this.
You know, I think the answer is yes. And when I did my calculations way back when, I sort of assumed that for every person diagnosed with an infection, there'd be at least 10 people that had the infection itself or the exposure.
10?
So, yeah.
Wow, that's a lot.
Well,
I agree with it, but that's a lot, yeah.
Well, putting things into perspective, you know, about 60 million Americans get diagnosed with the flu. That's an estimate because the Centers for Disease Control doesn't really collect data on adults. But let's say about 60 million adults in the United States, 1/5 of the population, 1/6, come down with the flu. Of that, 800,000 get hospitalized, and of that, somewhere between 10 to 40,000 will die of influenza. So right now, I think we're at something like 300,000 cases in the United States. So times 10, that's 3 million. Times 100, that's 30 million. So assuming 100 times more infected people, that's still less than flu. And I think that's what the number will come down at. I'm guessing somewhere between 10 to 20% of the population will be infected.
That's really interesting to hear. So our town is dramatically under testing, and partially because they can't, and so they are telling everyone to kind of self quarantine if they're. We've been self quarantined for, I think we're in week 2. I've lost count. My husband looked at me today and he goes, "Oh, I got to do that today." And I'm like, "It's Sunday." And he goes, "It's Sunday?" And so we're sort of losing track of everything.
I think I had a month because it did hit you were talking about the families that live together. My area has very high international population, and most families in my neighborhood have 2 to 3 generations living in the same home. So we have actually a good number, even though Texas is faring well, my county is not doing well. Or I feel like the numbers I'm looking at comparatively aren't doing well.
No, I can say it would be very interesting to compare outcomes in Texas and Florida and some of the other states that have been a little bit slow in instituting lockdowns or physical distancing, to see, you know, whether some of that actually was able to protect some of the economies, which I think is going to become more and more of an issue. Is the economic loss can be as difficult, more so, than sort of the public health concerns. I think one of the concerns that people had and certainly this is the case in New York, was the fear of overwhelming the hospital resources, the so-called surge. And that was, I think, one of the most important objectives in sort of flattening the curve, was to give time for ventilators to be built and to be reallocated, for masks to be made, for people to be prepared, and to reduce the stress. Fortunately, here in Ohio, we're in a pretty good position. We have enough ventilators, enough surgical masks, personal protective equipment, rooms are available, and I don't think we're going to get that surge. But at least people are prepared. And this also gives times for antivirals as well as vaccine development.
A lot of the flattening the curve from the very beginning has just been to, not that there's a cure for it coming by flattening the curve, but just to give that relief to the hospital systems so there isn't an overwhelming surge.
Yeah.
So I think my favorite part of reading your posts every day are that at the very end of each and every post, you have kind of this paragraph that and it's become this thing that I repeat in my house now. I walk through the house, I'm like, take your zinc, take your zinc. And they're like, what are you talking about? And I'm like, you don't even know. Okay, you don't even know.
I would add, I would like to have your end paragraph plus Dr. Shimamura's calming voice saying everything's going to be okay. That will get through every day of this quarantine. Between your info and just Dr. S could say nothing. Just her voice alone is very calming. I might ask her to record.
Okay, I'll say everything will be okay.
Yeah. We thank you so much for your time, Dr. Corey. You're so busy. I'm so touched that you're doing this for the community. Thank you so much. And
it's appreciated from all of our families, I know.
Well, thank you, and stay well, stay safe, and stay sane. Okay.
We'll take our zinc too. We'll take our zinc.
Okay.
No SIBO effect.
Thank you for everything, Dr. Corey.
All right, everybody stay well.
Thank you, Dr. Corey.
Good night.
Good night.
Oh, we went over the hour. Sorry, guys.
I know. We had to ask the tiger question. We threw it in last minute, but I feel like you guys wanted to know about the tiger, and then.
There tends to be a fascination with tigers in this country right now, and I think I don't know what it's from, but
I actually had a tiger mask just ready. I'm so obsessed with the Tiger King.
Masks. Cool. This is all I have. And
there is a lot of fascination with the tigers right now. So we're going to keep these shows. We have multiple shows coming. We have Nancy Sankata coming on. We have Dr. Huda coming on soon to talk about more of the psychological aspects of this. I
can Nancy saying Dr. Corey's a famous paragraph.
Yes.
Why not?
I like that idea. So we're sorry we went a little over today, but I think it was needed. Thank you, everyone that's tuning in from around the world. It's incredible.
We will put in the comments Dr. Corey's. Sorry, Nicole. Someone had asked how to see his posts every day that we're talking about, and so we'll make sure we link. Nicole and I will share it somehow into the comments so you can see.
And as a reminder, you could win Rona. She is so angry. She's like, everyone's home hoarding toilet paper. She is not happy. She wants to infect more people.
She's not happy that everyone's watching the Tiger Show. She wants them to be out petting tigers.
You could win Rona by interacting with this in any way, sharing it, hosting a watch party, making a comment, liking it,
messaging us questions,
asking a question in any way. So thank you all that logged in, and we'll post our next show soon. So we are busy on quarantine. Busy.
It's not like we have anything else to do. I mean, I'm not busy at all.
And whatever else we got going on.
You're baking, I'm sewing things.
Be safe.
Bye, Nicole. Have a good night, guys.